Rob, describe what the clinical experience for students enrolled in Paramedic Clinical 2 will be like.
The Paramedic Clinical 2 course is their second clinical course. The focus for the students in this time period is basically what we call our assessment-based management course, taking the foundational knowledge they learned in their first year of paramedic and transitioning them into their second year. So taking all that base knowledge, the skills development that has been done, and developing their critical thinking ability in both by using scenarios in the classroom and their field experience during this course to develop them and prepare them to be an independent team leader beginning in the fall. So this semester we're focusing on developing that critical thinking piece and engaging team dynamics. So for preceptors in the field, that means the provider should now start to be exerting confidence and exerting themselves as the lead in the patient care experience. Although that's our expectation, we also want to make sure that preceptors are comfortable and confident in making sure that all safety measures are taken, patient care is not affected, and they validate everything from the student, ensuring patient safety. Although the student is assuming that lead role, they still need to be somewhat supportive in the process. When we talk about lead as a student, we want to make sure that the student is developing those differential diagnosis, performing skills, establishing the treatment process, which includes consulting as appropriate, and then afterwards, post-call, making sure that there's a roundup or conversation about how the call went, other treatment options that may have occurred, how things may have transitioned differently or order of operations for different skills, but providing quality feedback so that the student can make adjustments and continue to grow into that lead provider role.
Specifically for Paramedic Clinical 2, how does the student's role evolve?
So this course particularly takes, again, someone from learning the ALS experience and observing the preceptor as they take the lead. This course from beginning to end, in the beginning they're likely still observing a little bit, but by the end of this course they are expected to be able to be the lead provider when it comes to introduction, assessment process, and even directing members of the team. So the preceptor might find themselves performing a skill while observing the student interact with the patient and developing that patient rapport.
Rob, can you describe what the expectations are of the preceptors and their role in the student experience in both field and clinical rotations?
So throughout our program there are specific expectations for each course, but today we'll talk about the general expectations across the board. First, I'll start with our field preceptors. So for field preceptors, number one, they are extension of the classroom. Their role is to engage our student, both actively during calls where they're assessing patients and performing skills, but also back in the station during downtime, reviewing paperwork, reviewing cases, protocols, medications, and so on. And the focus is that they are engaged in the learning process, and there is a seasoned resource for them to use as they continue to grow and mature throughout the program. In the hospital and clinical setting, the preceptors are expected to also engage, but in a different way. In the hospital setting, they could be in respiratory or an emergency department or a NICU, and the idea is that the preceptor engages the student in developing their sense of awareness about those individual specialties, in addition to developing the assessment process and furthering the skill level of the student. This especially becomes true as they continue towards the end courses of the program, where we're really developing those critical thinking skills. But our preceptor is the tie between the classroom and the hands-on skill development setting.
Now that we've talked about expectation, what type of documentation is required to validate this process?
One of the biggest things that is required in any program is documentation. So for our students, we use the FISDAP online access, and there's also an app that students tend to use. The FISDAP program allows us to schedule shifts for students, track preceptors, and track shifts for them. It's a student's responsibility to take the information and skills that they perform in the field or in the hospital setting and enter that data and information into the system. This allows us to track the opportunities that they had, what they were able to fulfill, maybe look at any shortcomings and be able to make adjustments in their clinical experience. As far as the preceptor's responsibility, when the students are in each individual setting, there's a paper document that needs to be completed by the student, accurately reflecting the skills, patients, chief complaints, and age groups that they're exposed to in that process. The preceptor then reviews the information in the form. They initial and sign that those skills were completed, essentially validating the information. And there is also a chart on the form where they can rate the student competency level, whether they need more skill development, whether they were pretty competent but maybe needed to develop a little bit more confidence, or the top level, which is they were confident and completely independent. So this provides not only the student real-time feedback during the clinical shift, but also we can reflect afterwards, not only with the preceptor in downtime and the program when we do clinical education meetings with the student.
What's the clinical scheduling process, and how do preceptors receive the information about their students?
As we think about the scheduling process, it's easy to break into the two separate areas. First is field scheduling. So field scheduling occurs with the individual operational programs that we have affiliation agreements with. And this can change from year to year and semester to semester. The important thing to note is that we have to have affiliation agreements with these operational programs. And they work with the clinical education coordinator to set schedules and assign preceptors that they vetted and support through the program. Depending on where the student comes to us from, some we have regular agreements with that provide us preceptors, and the student will schedule independently with them and or directly. There are other affiliates where they provide me available dates and stations, and I place that in the FSDAP scheduling for the student to schedule, and we coordinate where to report and who their preceptor might be for that day. So those are two distinct processes, and depending on the field vendor we're working with, it's one way or the other way. When it comes to hospitals and looking at different units, whether it's the NICU, emergency department, respiratory therapy, peds, and so on, those clinical sites, once we submit to them and they clear students to come, they'll provide us the dates and shifts that are available. The students will go into FSDAP, sign up for the shift, and we provide that list to the individual clinical sites so they know who to expect and when to expect them. And that's the general process for hospital clinicals.
What are some of the challenges that may be encountered by the student and the preceptor?
Typically tend to look at these in two different areas. The first is administrative. When we think administrative, those are things like our expectations for our students. So for example, all of our students from CCBC we expect to report to any clinical assignment professional. That includes their attire, complete professional uniform including their identification and a stethoscope, a professional demeanor. They approach the situation with professionalism, including their interaction with the preceptor, interaction with other hospital staff or other field providers, as well as the patients themselves. Any deviation from those standard expectations, whether it's tardiness, the student leaving early, the student demonstrating bad affective behavior, which is that professional demeanor, and uniform, we expect to be reported back to the clinical education coordinator. It's important that our students are there ready to be engaged, just as the preceptors have taken the time to be ready and engaged with our student. On the other side of that coin are things like injuries, things that we don't expect to happen, but when they do, we also want to be prepared. If an injury happens to a student during the course of a shift, and it could be anything from an ankle sprain or a fall or a seizure to a needle stick. The first thing is to make sure that the situation's addressed immediately, whether they need medical attention, 911 gets called, or they get transported to a hospital. That obviously needs to happen first. As soon as it's appropriate and accessible, the clinical education coordinator needs to be contacted. That will start the internal process here at the college. As far as anything that happens in the field, once the student gets medical attention or any immediate concerns are addressed, there's paper documentation that needs to be filled out, which includes a first report of injury form, and then that gets turned in along with any documentation about the incident. On the academic side here at the college, it's just a chain of notification. When it comes to seeking treatment, a lot of times clinical sites ask about, well, who's a preferred vendor or who's insurance. So here at the college, our students maintain their own insurance. So any injuries sustained, anything like that, it's their choice where they go for medical treatment as per their normal insurance process. So now that we've discussed some of those issues or concerns that may arise during a clinical shift, although we can't predict all of them, there are always questions that arise from preceptors and sites and students. So if anyone has any questions as the program continues or through their stint as a preceptor, they should be directed through the chain of command to the clinical education coordinator. It's impossible to predict all questions and scenarios out there, and that's why we try to work with all our clinical sites and maintain that communication.